Assalamu alaikum, the long clinical consultation day. First scenario, Mr. Atif Kamal, 65 years old, gentleman with a complaint of vomiting. His blood pressure 150/90, pulse is 90, temperature 36.7. Examine him, take history, and address his concerns. Yes, here you go, Dr. Dr. Rasha?
Yes.
Yes, you can start.
Yes. Hello. My name is Dr. Al-Mahdi. I am doctor in medical ward today. Can I confirm I am talking to the Mr. Atif Kamal, 65 years old?
Yes, I am.
Mr. Atif, we are here to ask you some questions and examine you and address your concern. That's okay with you?
Okay.
Can you tell me what brought you on a clinic today?
Yes, I'm suffering since 3 weeks from being sick and throwing up.
Okay, I'm sorry for your suffer. Can you tell me more about the throwing up? Once it started, it was sudden, gradually. Is it the first? Okay. Can you tell me more about the throwing up?
Yes, this started since 3 weeks, as I said. Started with more sickness and feeling sickness. After that, I throw up. Maybe in the first of this duration, started with 1 time, 2 times per day. In the last days, become 4 times per day after meals.
You mean started the throwing up since 3 weeks, 4 times per day?
Yeah, yes, the last days or the last week become 4 times per day.
Yes, in the last 1 week, it's become more progressive and increase. Am I right?
Yes, yes.
Okay.
I
Is it
visited
the first?
the GP. Yes, I visited the GP and give me some medications, but it not relieved.
Is it not improved after started some medication?
No.
Okay. Can you tell me, is it the first time or you had previous attack?
Yes, yes.
Is it the first time?
Yes, before this is 3 weeks, just I feel some fullness in my tummy and some feeling sickness, but not vomiting.
No throwing up. Okay. Can you tell me regarding the amount? Is the large amount or medium amount? Can you describe exactly the amount of the throwing up?
Actually, I feel I throwing up all the food I take.
Regarding the amount, is large amount or moderate or small?
I don't notice actually.
Do you notice any color change like green color or yellow color?
No.
Any blood?
No.
Do you feel any history, any feel sick before into the throwing up?
Yes, yes.
Okay. Any history of tummy pain?
Yes, I have stomach pain. Yes.
Since how long you suffer from the tummy pain?
I also started with this throwing up.
Where exactly the site of the pain?
In my stomach here.
Do you notice anything making to the pain is more or increase?
After meals, after food.
After food, anything is making to the pain is improved?
After throwing up, I become relieved.
Okay. If I give I score from the 1 to the 0, the pain, how much you give?
It may be 4.
Can you describe the nature of the pain?
Like heaviness in my stomach.
Heavens. Okay, I'm really sorry. Any history to that? Any tummy distension?
Sometimes I feel yes, my tummy is distended.
Is bigger than before?
Sometimes yes.
Okay. Any history into the change into the bowel habit?
No.
Any history into the bathroom?
But because this throwing up, I think is become infrequently like before the going to the bathroom.
You mean decrease the amount into decrease the numbers go to the bathroom?
Yes, that's right.
Any history of hard stool?
No,
Any history to the black stool or history to the passage blood from the back passage?
no,
Any history to the loose motion?
no,
Okay. Apart from that, any history of high body temperature?
no.
Any history of what about your weight?
I noticed that maybe lost some weight, but not more. Maybe 1 kilogram or 2 kilogram through this this 3 weeks or the last 1 month.
Okay. Any history of what about your appetite?
Actually, my appetite is good, but I became fearing from eating because this vomiting.
Okay. Any history to the lumbar bump to the anywhere?
No.
Any tiredness?
Yes, I become tired because no food.
Okay. Any history? Anyone come into you better than before?
No.
Any bleeding from any side?
No bleeding.
Any yellow discoloration to your eye and your skin?
No.
Any painful soreness into your mouth, ulcer region to the mouth or soreness?
No.
Any difficult to the swallowing or painful to the swallowing?
No.
Okay. Any medical condition I should aware of?
Yes, I have. I am diabetic since 45 years. And
since what?
45 years.
45 years. Okay.
Yes.
What is the last accumulated blood sugar?
7.5 recently, but before was uncontrolled for a long time actually, and I have more complications from that. And one of these complications that I have renal failure. This has happened since 5 years because this uncontrolled diabetes actually, and I was on hemodialysis for 2 years. After that, I did renal transplant.
When you did the renal transplant?
Since 2 years.
Since 2 years. Okay. Which medication are you take for renal transplant?
Yes, my medication list. I am taking for renal transplant. I am taking tacrolimus and mycophenolate.
Okay. Are you compliant with this treatment?
Yes.
Okay. And you recently changed it into the dose or added any other medication?
No. Actually, I am was follow up with my kidney doctor.
Okay. Apart from diabetes, any medical condition I should aware of?
Yeah, hypertension also. But is maybe recently become uncontrolled. Today it is some little high.
The medication tacrolimus and mycophenolate, yes?
Yes.
Okay. Apart from hypertension, which medication are you took for high blood pressure?
Lisinopril, 10 milligram.
Okay. Apart from that, any other medical condition?
Yes, I'm taking insulin for diabetes and vitamin B complex also. This was for high cholesterol and proton pump inhibitors given by GB for me for this problem.
Okay. Okay. Apart from the surgery of renal transplant, any other surgery?
No.
Okay.
Surgery for this fistula in my hand.
Yes. Okay.
For dialysis.
Yes. Any history of blood transfusion?
No.
Okay. Any history of headache?
Sometimes, not.
Any history of fat or abnormal movement?
No.
Any weakness?
No.
Any pins and needle sensation?
Yes.
Okay, what exactly the site?
In my feet.
Okay, any history of cough?
Yes. Sometimes cough, but I was asthmatic since childhood, but now it's controlled, not more.
Okay, any coughing of blood?
No.
Any shortness of breath?
No.
Any leg swelling?
No.
Any chest pain?
No.
Any problem to the water work?
No.
Decrease amount or frequency or any change into the color?
No.
Okay, any joint pain, any skin rash?
No.
Any back pain?
No.
Any problem to your eyes? Blurred vision or dropping to the eye vision? Dropping to the upper eyelid?
Yes, I suffered from blurred vision the last year, but now it is good.
Okay. Apart from this medication, there's
It
no
is also complication of
diabetes.
It was a complication of my diabetes. Yes.
Any laser surgery for your eye?
No, just medication.
Okay. Any herbal medication? Any over-counter medication?
No.
Okay. What are you do for living?
I am retired accountant.
Do you smoke?
No.
Do you drink alcohol?
No.
Any recreational medication?
No.
Okay. Can I examine you?
Okay.
First of all, the vital sign, blood pressure sitting or standing. I want to examine into the hand of the capillary refilling. I want to examine the pulse. I want to examine if there's any tremor, if there's any flapping tremor. I want to check, tremor, any flapping tremor, any leukonychia, any sign to the anemia, blood pressure, sitting or standing, the pulse. I want to check into the fistula. I want to examine the eye of Baller and jaundice. I want to examine the lymph node and mouth if there's any cyanosis.
Anything in the mouth you want to examine?
I want to check into the mouth, yes, if the side effect of medication, gum hypertrophy.
Okay.
And also, I want to examine the neck if there's any raised GVB. I want to examine to the site into the patient, the site into the patient, the site into the briefcase inserted to the catheter. I want to examine the abdomen.
Okay, you can check the box, shot box for the pictures.
Okay. Yes, I want to check, the tunnel sign. I want to examine the lymph node. I want to examine the abdomen. If there's any, I want to examine palpated into the scar, the transplant scar, if there's any tenderness.
No tenderness.
I want to examine if there's any hepatosplenomegaly, or I want to examine the epigastric area if there's any tenderness.
Yes, there is tenderness.
I want to examine there's tenderness to epigastric areas.
Yes.
Okay. There's no any tenderness at the site of the scar.
No tenderness in the scar.
No tenderness. There's no any flapping tremor. There's no any sign to the anemia or jaundice.
Yes. There is another photo, Dr. Bassem. You can share it.
Yes. And also I want to examine the back. If there is any, examine to the kidney. If there's any, examine into the back. Examine the lower limb. If there's any pitting edema, examine to the ulcer.
2 minutes left.
And I want to examine to the back and to the chest if there's any crepitation.
Okay, no crepitation.
No crepitation. Mr. Okay, what's your concern? Mr. Kamal, what's your concern?
What I have?
Regarding to your symptom that you have, most probably you're throwing up, maybe related to the medication which using for the kidney transplant. Causing to the throwing up. And also the second may be related to the underlying cause, because it's one of the complication of diabetes. Yes, for that I want to do some blood test and imaging. Yes, I want to do some blood test and imaging. Yes is yes.
Yes, doctor. But actually, I fear this is maybe a cancer.
Your worry is understandable, but regarding to your condition, the cancer is the less likely you have into the cancer because you don't have into any alarming sign. Most probably, the condition may be related to the medication which are you taking for the renal transplant, maybe cause it soreness into your gut. The second, and also may be related to one of the complication to the long-standing uncontrolled diabetes.
Is it treatable, doctor?
Yes. Is it treatable? Yes. The first of all needing to the some blood test and imaging to confirm diagnosis. Most probably is treatable.
Okay. Thank you.
Do you have any other concern?
Thank you.
Time is up. Examiner questions. Dr.
Present your findings.
Mr. Kamal, 65 years old, presented with a throwing up since into the 3 week, associated into the tummy pain. There's no blood association to the tummy distension. Apart from that, he has known case of diabetes with a known case of diabetes and hypertension with hypercholesteremia and presented with a complication into the diabetes like patient known case into the kidney transplant. Patient in tacrolimus and microphenolate. Yes. Yes, regarding to the history, regarding to the examination, patient presented with the scar, and also the patient there's tunnel sign. There's no sign
Where is the
of
scar?
yes.
Where is the scar?
The transplant scar. And there's ulcer into his food, the complication into the uncontrolled diabetes, long-standing diabetes.
Okay.
Yes.
What's your differential diagnosis?
My differential diagnosis may be related into the medication which taken for the kidney transplant, like sacrolimus and tacrolimus and microphenolate mofetil. The second may be gastric due to the long-standing uncontrolled diabetes is called gastroparesis. Is the one of the complication of diabetes, long-standing uncontrolled diabetes. For that,
else?
I want to do yes. Other. Yes, the third differential diagnosis, the failure to the kidney transplant. But apart from that, there's no any other sign of the transplant failure.
Okay. So how can you investigate this patient?
Yes, apart from the basic investigation, I want to do full blood count and renal function test and liver function test, serum electrolyte. And also I want to do the blood sugar, and also I want to do the drug level, and also I want to do the infectious screen. Yes. Yes.
Okay. You
yes,
mentioned
to rule out the gastroparesis, there's something, I think gastropathy, there's some investigation, but I am okay. Forget.
Okay. Okay. So if this patient has gastroparesis, as you mentioned in your differential diagnosis, how you will treat him?
Yes, regarding the gastroparesis, may treat in some medication with the called prokinetic medication. And there's, if not improved, there's a gastric pacemaker.
Okay. Okay. Anything else?
And treated the treated the diabetes.
Okay. What's the complications? Other complications of diabetes other than
other complication? Patient has history of blurred vision, retinopathy, and history into the pins and needle sensation, neuropathy, autonomic. Yes. Microvascular complication.
Okay, not in this case. In general, what is complications?
Yes, in this case, patient has into the ulcer in his leg, peripheral neuropathy.
Not in this case. Not in this case.
General?
In general.
Yes, in general, diabetes affected micro and macrovascular complication. Macrovascular complication like heart and stroke, like MI, like coronary artery disease, like stroke and TIA, like peripheral vascular disease, and microvascular complication, retinopathy and nephropathy and neuropathy. And also the recurrent attack of hypoglycemia.
Okay. Okay. So
And skin
is
manifestation,
this
yes. Mhm.
gastroparesis? It is one of the autonomic
Autonomic
dysfunction.
manifestation. Yes, autonomic
What is
dysfunction.
the other autonomic?
Yes, other autonomic postural hypotension. The other autonomic, and the patient autonomic, yes, postural hypotension, and the patient the impotence, yes, impotence.
Yes.
And
Okay. Thank you.
Yes, time's up. Question is done. You can comment now, Dr. Hani.
Okay, well done, دكتورة Rasha. صح?
yes.
Well done. What do you think you missed in the history, Dr. Rasha? You take a long time in the history, but you missed some things in the history. What do you think you missed?
History ask about the patient, the impotence.
Yes.
History to ask the intimate relationship.
Yes, the sexual history. The sexual history.
Yes, yes is important.
Family history.
Family history, yes.
Okay. Okay. Yes, travel history also. Yes, that's right. Okay. About this is missed things in the history. In examination, you have little time for examination, so you missed some fundoscopy. You don't over fundoscopy. You need to examine the lower limb neurologically, because he have peripheral sensory peripheral neuropathy, pure sensory neuropathy. If you examine the patient, okay. In examination also, you examine the abdomen. Yes, okay. You forget to examine the AV fistula, if it is functional or not. Okay. Okay. So this is from examination. About the patient concern. This the differential diagnosis here, Dr. Rasha. It will be first diabetic gastroparesis. Okay. The second maybe drug induced. Third, maybe gastric outlet obstruction, maybe ulcer related or malignancy in this age, with patient taking immunosuppression, with some loss of weight, maybe it is, but you must bet gastric outlet obstruction, maybe gastric ulcer or peptic ulcer related, or malignancy. So if you ask it about the content of the vomiting, it will be food particles, not digested. Okay. So you will put the gastric outlet obstruction in your differential diagnosis. You will put also the peptic ulcer disease itself. Okay. And drug induced. Okay. So
yes, but SAID I drug induced. SAID is the one of the differential diagnosis drug induced.
Yes, yes, that's right.
Okay.
So in this case, it will be gastroparesis. How you will explain the gastroparesis to the patient?
Before moving, Dr. Hani, is there any family history to support this cancer? If she asks about it?
Yes, yes. His father died with cancer, with colon cancer.
Perfect. Okay. So this is the hint. Whenever you will have the family history as a question, you might have
But
family.
colon cancer not presented with vomiting, presented with
No,
constipation more than vomiting.
GI cancer generally, not as colon only, GI cancer. Okay, GI cancer as a family history, it can run in family, not specifically the colon, but as all GI cancer. You know, some families are known to have cancer, either liver or organs like ovary, female, in the male, for example, cancer, testicular. So it's not, I'm not saying supposed to be positive for cancer colon only. Any cancer in the family will give you a hint there is possibility to have a cancer in the son or the generation. Okay, continue, Dr.
But
Hani.
the other alarming symptom is not presented. Okay,
No,
okay,
no,
for
he said no
cancer.
appetite, no decrease weight
Just
as
only
well.
just only 1 kg in the weight.
Yes, but it's not strongly positive, but still you have a possibility. You said it's likely, one of my list, right? Okay, yeah. So put it in your list, even down, but still one of the possibility. This is the hint of the family history will be the hint for this differential. Okay, I'm trying to just, I don't know the case, but I'm trying to clarify the things with Dr. Hani. Okay, continue,
Yes,
Dr. Hani, please.
Okay, just I asked Dr. Raj about how to explain gastroparesis for the patient. If this is a diagnosis, how you will explain? You want to ask to answer? You know, or I say.
Gastroparesis is
Okay, you can say this is a condition where your stomach empties food more slowly than normal. Your long-standing, in your case, this may be related to long-standing diabetes, where over time, the high blood sugar can damage the nerve cable or the nerves that control your stomach muscles. Okay, and when this nerve don't work properly, the stomach doesn't push food forwards as it should, and this causes food to sit in the stomach longer than normal and causing these symptoms you have. Is it a cancer? I highly appreciate your concern. These symptoms, and from your history and examination, cancer is not expected, but must be excluded, need to be excluded. So we will do some investigations and imaging to confirm our diagnosis and exclude other diagnoses. Is it treatable? Yes. About the gastroparesis, this is treatable, and our treatment focus will be focused on to get better blood sugar control and changing how and what you eat. I mean, smaller and more frequent meals, and medication will be prescribed to help stomach to move the food along. And with a proper management, symptoms can often be improved, even though the condition itself is usually long-term. Okay, about the investigations, the basic investigation, as you say, and to confirm the gastroparesis, it is called gastric emptying scintigraphy. Gastric emptying scintigraphy to confirm the diagnosis of gastroparesis. Is a gold standard here. Okay, and you need to do investigation to exclude other differentials: abdominal ultrasound, CT abdomen, upper endoscopy. Okay, how can you treat gastroparesis? It will be multidisciplinary team approach. You need to involve endocrinologist to strict control of the diabetes, a neurologist to treat the neuropathy, gastrologist, nephrologist, dietitian, and general surgery even. Treatment will be non-pharmacological in the form of patient education and counseling, tight glycemic control, dietary modification, I mean small, frequent meals, okay, with low fat and low fiber diet, soft liquids foods, avoid smoking and alcohol. And you can advise the patient to sit upright after meals. And you need to pharmacological will be prokinetic agents like metoclopramide and erythromycin. The second medication will be proton pump inhibitors. We will continue this medication, and antiemetics for symptomatic control, like dimridone or Lexat. Okay. If the case is not responding or refractory, you will consider for enteral feeding. Okay. And the surgical option, it will be gastric electrical stimulation. Okay. This for treatment of gastroparesis. And you need to treat the complications. Malnutrition, dehydration, if the patient dehydrated, and diabetes control, treatment of the neuropathy. Okay, and foot ulcer, Okay. About the question about the complications of diabetes, we can classify it as to acute complications and chronic complications. The acute complications will be in the form hypoglycemia or hyperglycemia. Hyperglycemia may be DKA or hyperosmolar hyperglycemic state, or infections, acute infections. Chronic complications, as you said, we can classify it to macrovascular and macrovascular. Micro, like diabetic retinopathy, diabetic nephropathy, diabetic neuropathy. Retinopathy, neuropathy. Macro, ischemic heart disease, and stroke, and peripheral arterial disease. And another classification is other complications like diabetic foot and autonomic neuropathy. Autonomic neuropathy, as you said, will be orthostatic hypotension, erectile dysfunction, and gastroparesis, which is our case. Okay, that was my comment.
Okay, what's the point is missed into the history? Just only family history?
Sorry?
What is the point is missed into in history?
Yes, I say to you, you missed family history, travel history, and sexual history.
Okay.
Okay, so back to the skills, Dr. Hani. Let's comment based on the skill. Started by physical examination. What do you think? Did she examine everything?
I think if she have a good time, she will examine good, but she missed to missed some
neurological examination. Okay.
Yes, but I think because in the exam only the neurological examination maybe because the time can be over.
Yes, but consider time management, Dr. Rasha. The problem here, you took very detailed and good, perfect history. Yes, I agree. You cover everything in the history taking, but you took the time of examination. So you did the history taking perfect, but it was on the time of examination. You didn't do the all exam. Even you offer all of the steps. I want to do 1, 2, 3, 4. You started, yeah.
Yes.
So you will be trying to be more targeted question to the point with concise analysis of the complaint because you took long time to analyze the vomiting. Okay. Yes, it was good and perfect. I agree. You did everything regarding the analysis, but you took long time. So you will be trained to do this question in a fluent and rapid way, not to have this long time for the history taking. So the physical examination will be deducted because of this one. You didn't examine the motor or the neurological examination. Even if you offer it, you have to do examination. Even the steps of examination for the abdomen, the scar, the transplant will take time. You didn't do it. You just said, I want to examine 1, 2, 3. I want to examine the kidney. I want to examine the chest, the back of the chest, the tunnel, the scars of the catheter. But you didn't do. When you do the steps, it will take longer time. At least 4 minutes before the consent. So whenever you feel yourself took long time to ask history, try to move forward to examination, and you can take history or you can ask other question during examination steps. Like, do you smoke? Do you drink alcohol? The systemic question, the systemic review question. You can ask also, do you have any headache, blurring vision, while standing and asking the patient or examining the patient. Okay, so let's go back to the comments. The skills. Second, physical or identify the signs
Yes,
because you.
it will be decreased according to the physical examination. It will, يعني, I can give her borderline in the physical examination
Yes.
and identifying
Okay.
the signs, and the other may be satisfactory.
Yeah, I agree. For the history taking, it's satisfactory. She asked everything apart
But
from
regarding this patient, there's any physical sign missed?
yeah the peripheral neuropathy.
Mm.
Yes,
Fundoscopy. So,
and fundoscopy you didn't offer. Also the heart examination, maybe also chronic heart disease or ischemic heart disease. Again, as I said, it's okay to offer, but the best is and the optimum is to do the examination, not to just offer. Okay. The most important in the clinical communication, two very important question, and it will minus also, it will affect the mark of welfare. What do you think, Doctor? Welfare. What welfare point can be affected your mark?
History
Since
of low blood sugar.
History
okay,
of
this
what?
is one of the point. Hypoglycemia, you didn't do it, and something affecting the vision, related to the vision. The
Driving.
driving. The driving, right?
Mm-hmm.
You didn't ask him about his driving. Does he drive?
Mm-hmm. Okay.
Yeah, so, but still, your history or your detailed history was perfect enough not to minus. But again, remember that it's not only take history, it's a station of examination along with taking history. You know, the old format, there was a station which is taking history, all the station, just only take history, no examination. This is the old format of PACES. But nowadays, or the new format, is to take history plus concise and targeted examination. Here you took good history, perfect, detailed, but still, and structured, by the way, organized. I like your approach, it's my best approach. But still, based on the time of examination, you didn't do the good and target examination. So, what you will
actually,
do? Yes.
But
Dr. Bassem, it is
mm,
actually it is our problem. All of
All
us.
of you, exactly, yes.
Yes. Our problem to how to make the history in the time, the right time. I think the time of history mustn't be increased 8 minutes. All the history from
Yeah,
analysis of the complaint until the social history. It must take not more than 8 minutes. After
you
that,
know,
5 minutes for the examination and 2 minutes for the concern.
perfect. You know what the problem, Dr. Hani? You don't have watch, or you cannot, you can look at your watch, but not frequently. Okay? If they allow you to wear your watch. There is a clock, yes, there is. Sometimes in some stations, in some centers, they can put a clock in front of you. But if you kept looking at the clock and counting the time, how many, you cannot do it. How you can do this? By training on the practice. If you do the analysis and the approach in fast and fluent way, believe me, you will finish it in 8 minutes. Of course, if you don't have complex cases or complicated cases like our scenario today, there is a lot of finding, but don't give a lot of time to analyze the vomiting itself because I know already there is vomiting. What I want to roll out in this vomiting, which is very important, the blood and the content itself, as you said. But the amount, it's okay, either small amount. The patient will not come to you unless he has significant amount. Okay, the relation to the meal was good question also to ask, and the onset course duration. There is tummy pain as well, so she analyzed it very perfect. What is the tummy pain scale? and where exactly, and moving to which area, where exactly. Okay, she did everything in the GI analysis. Imagine maybe 5 minutes for the GI analysis only, which is the relevant system. Even the soreness she asked about, perfect. The difficult swallowing, perfect. All of them are perfect. But again, you took the long time of history, which affected your time to do the examination properly. That's why you didn't finish your examination, and it might affect your marks in the examination and physical examination and identify the physical signs. 8 marks. That's why also you have minus 4 marks in our station today. But in the exam, maybe you will have less time because the examination steps will take time. It might harm the time, or it might affect the time of concern. Here you remember to ask the concern. And by the way, try to answer the concern shortly. Always I ask and advise all of you. Don't be volunteer to tell him about the investigation unless he will ask you, doctor, what you will do for me. You have a condition called gastroparesis. It's a condition where you have long-standing diabetes complicated by this complication. It's, as Dr. Hani said, difficult to empty the stomach, taking long time. What you will do, doctor, for me, I will admit you to run some blood tests and other blood workup, or sometimes we can do imaging and so on. Is it serious, doctor? Is there any cancer? I appreciate your worry. Your worry is understandable. Possibility of cancer is not in our list today, but since you have cancer, family history of cancer, you have to say, I can suspect a cancer, one of my lists, or one of my differential. This is what I want Dr. Hani to comment. Once he commented, or once he has the concern of, do I have a cancer? You can say to him, yes, since you have history or family history of cancer, I am so sorry. I'm afraid to say, could be one of our possibilities. Okay, so you are giving evidence in the history of family, or giving evidence of family history, and evidence of finding in the history itself, losing weight and losing appetite. Otherwise, really, the approach, the scheme, the analysis, the history, everything was perfect. Apart from family history and travel history, if you have time. Again, if you shorten the time to do the analysis of the complaint, you will do this case perfect, Dr. Rasha. Okay?
Yes, but Dr. Bassem, I have
Yes.
comment. Regarding this patient, you said the long history, but regarding this vomiting, I made a plan. The vomiting, yes, first of all, the complaint, also course duration analysis of the vomiting, the color, amount, frequency. Then the vomiting apart from the GIT symptom. You need analysis all the symptom of GIT. After that, do the patient post medical condition. The patient diabetic or hypertensive, you need ask about all the complication of diabetes. Okay, and the patient past history of surgery. We need to ask about renal transplant, which medication, recently changed the medication, and after that, a systemic review. I think there's no detailed history. All of this information is important.
Yes,
Yes,
I
this is my
said all
problem.
of them
يعني
are
حتى
important.
I'm do other session with the other friend. You said I taken long term history, but everything in every point into the history is important.
Okay, so what can we remove from your history or analysis of the vomiting, for example? You ask the question of the amount twice. Yes, it can save some seconds, but at least you can do this time for the examination. What the benefit of knowing the amount now? What the benefit of the amount of
Yes,
vomiting?
if the large amount, the vomiting patient,
So,
patient dehydration, patient you need admitted to the hospital, patient postural hypotension. If the large amount of vomiting.
but if it's a fluid, this is food content. Okay.
Yes, but if the patient large amount and more frequency, if the vomiting patient risk to dehydration like diarrhea, like polyuria, patient lost a lot of the fluid.
So yeah, so some question will help you to ask the proper question. If you ask about the nature of the vomiting, and the Dr. Hani told you it's food content, no need to say the amount, because the food content means what he eat already he vomit. If the patient doesn't have food content, now you can ask about the amount because it's fluid and the fluid will be lost, and the patient will be dehydrated. Or you can know the dehydration from other signs like postural hypotension, like feeling dizzy. I'm trying to find some question which is little bit, I'm saying little bit, not that much, but little bit unnecessary. Okay, because you cannot do all things together. You cannot do the whole detailed history and also the all steps of physical examination and identify the signs. Something might be affected, either the history, clinical communication as skill, or the other examination skills, which is 2 skills. See how many skills a mark will be minus. You have 2 skills for the examination, which is physical examination and identify the sounds, 8 marks.
Okay.
And compared to the clinical communication, only 4 marks, right? Yes, Dr. Han.
Yes, I want to say what you say now about we can do. I watched past test videos about the long clinical consultation, and I find that they do the analysis of the complaint. After that, he do the PDFs اللي هو past medical and surgical history and family history and social history and drug history without doing the systemic review. After that, start the examination. If there is a time, still we can do the systemic because the communication, the history is just the communication for grades only. Okay, but if you don't do the physical examination probably, it is for and physical finding will affect it, and also the patient concern may be affected.
Of course,
okay.
the concern will be also affected, yes.
So systemic.
But regarding this patient, you need to do systemic review because patient diabetes
Yes, that's
check
right.
underline other complication of diabetes into the other part into the system, cardiovascular and patient CNS and patient renal. You need to do systemic review.
Okay,
yes, that's right. But if I asked you what you will leave if you are يعني بالعربي مجبرة انك انت تترك شيء من الهيستوري، هتترك ايه؟ You understanding me?
Yes.
But Dr. Hani, I want to also to comment on this. If you overlook the systemic review, also you might, of course, you will not have the question for example, the urine output, right? The water work, which is very important. You will discover the functioning of or the function of the renal transplant from the systemic review, which is the urine output, any change of water work, right? What I want to say, put everything and do everything in balance. Don't do everything as history taking only. Don't do the all examination only. Don't overlook the systemic review. Do it, but within limited time. All the steps, do it in limited time. The analysis of complaint supposed not to take from you maximum 3 minutes. Okay, we have now 3 minutes for the analysis of the complaint and the relevant system. 3 minutes. And the constitutional symptoms, you can add it to the 3 minutes. Past medical history, you can give 1-2 minutes maximum. So now you have 5 minutes. Okay? You have 3 minutes to finish the systemic review and family travel history, and occupational questions. 8
but
minutes.
I think this patient travel history is not important. Why ask
Forget
about the
travel history in this. Okay, forget about it. I didn't minus you, by the way, in the clinical communication, but I'm just reminding other candidate. There is family history important. There is travel history might be important, but our today scenario is not important. So let's continue our timing. 3 analysis of the complaint and the constitutional symptom and relevant system. Past medical history 2 minutes, now 5 minutes. 3 minutes for the systemic review. Believe me, it will not take all this time because the systemic review, if you remove the affected or relevant system, you will have a few questions. 8 minutes now. Whenever you finish this, continue or move forward to the examination. You have to examine the system affected and the other finding according to the systemic review. I think 8 minutes to 14, you have good time. If you say, for example, it's reached 9 minutes, still you have from 9, 10, and 11, 12, 13, 4 minutes for the examination, and 2 minutes, the last 2 minutes for the consent. Again, Dr. Hani, maybe the case will not be that much complicated. They do calibration of the case to give the candidate the finding which can be already fitting the time. Okay, they are doing this.
Actually, this is this case from Oman Center recalls.
Okay, perfect. But the other finding, like transplant, AV fistula, also you give her some history and some time to the past surgical history, for example, the AV fistula. Maybe they will not give the patient with AV fistula. Okay, I won't say it's not in full history in this way. Sometimes they can minimize the history to give you a chance to examine the patient. Okay, and according to your approach, even if you will not take all the history, but you did the all history relevant and you did the perfect examination, the examiner will be looking to your approach in general, the all station. So they can give you the mark even you miss something which is not relevant, or maybe it's not related directly to the case. Okay.
Yes, agree with you, Dr. Bassem, but I have comment on Dr. Rasha.
Yes.
Sorry, Dr. Bassem, because this case is very common in Egypt, very common in Cairo, Alexandria. So this case, Dr. Rasha take very long history. She started examination at 11 minutes and also started to analyze the side effect of diabetes at 6 minutes. This case has two components. One component, the first component is diabetes. So first thing you have to analyze the side effect of diabetes. 3 macro, autonomic plus Charcot, plus the examiner will not forgive you about if you didn't ask about any history of low blood sugar admission in the hospital or any history of low blood sugar, because you will stop driving. How you will stop driving if you don't know about any history of low blood sugar? That is the first thing. The examiner will forgive you if you forget racing heart, if you didn't examine the back of the chest, but he will not forgive you if you didn't examination of diabetes, which is peripheral neuropathy plus Charcot plus the vision. That is the examination of diabetes. So Dr. Rasha forget about the ulcer in the back of the foot. So it will, I think, lose many marks in the identify physical signs. If you didn't tell the examiner he have ulcer in the back of the foot.
Yes, comment about ulcer.
You comment? Sorry, Dr. Rasha.
Yes.
Okay. Okay. So first examination of diabetes, which is peripheral neuropathy. Believe me, if you didn't examine the peripheral neuropathy of the patient of diabetes, even he came with vomiting, because it is autonomic neuropathy. It is a side effect of diabetes. So he will not forgive you. Second thing is about the blaring vision. About the fundus, also you have to offer it. And the second thing is the examination of the kidney. The examination of the kidney will take time because you first check the fistula. This case came in Cairo, but it is not kidney transplant. It was a patient with end stage in regular dialysis. Came the same dizziness in patient with diabetes and end stage renal disease. So you have to examine for the fistula. You have to examine for the kidney. What is the cause of kidney failure in the patient? Like that. So this case was two component, diabetes and the kidney. I think if you do examination of diabetes and examination of the kidney, I think the examiner will give you the full mark. What is the problem? You did the case as a whole case. So you had this very common case in Cairo, side effect of diabetes. So you have to learn it well. Thank you, Dr. Bassem. And also, Dr. Rasha, not to stop driving. My case in Cairo was cytotoxicosis, and I stopped the driving. Okay. Even I asked about any blaring vision. Yes, there is blaring vision, but when I do the visual field, no visual field loss. Okay. And the examiner tell me why you stop driving. The patient doesn't have only blaring vision. So I tell the examiner I will refer to the ophthalmology, and he will assess my patient. So you have to stop driving in this patient. Okay, Dr. Basim, thank you.
Okay, thank you, Dr. Mahmoud. The last comment regarding it, because we took a lengthy discussion about first case. The last comment: the all examination steps will not be done. The examiner will guide you
Yes.
what to do and what to
Mhm.
miss or what to overlook. So you will offer, I want to examine the kidney. Either he will tell you yes, go ahead, or no need. It might be hurting the patient now, so he will focus on the part will be affected in this scenario today. So the abdominal examination as epigastric area and the peripheral neuropathy as well. The kidney itself, I think the examiner will tell you no need to examine because it's functioning, nothing is there. So he will
Yes.
tell you you can skip. The other sides of immunosuppressant side effect, you can do it quickly. By the way, the steps: open your mouth, open your eyes. It will not take seconds, just seconds. The thing will take time. The neurological examination, for example, tone, power, reflex, coordination, sensation. Uh, anyway,
And I
yeah.
think Dr. Basim, Dr. Rasha forget about upper GI in the scope. Yes, in the clinical judgment. Didn't tell the
Yes.
and yes, it is a must. The patient who's vomiting and old age is 25 years old. Even if she doesn't have
Need
any
to
family
exclude,
history,
yes.
exclude, yes.
Okay, but still, the approach was good enough to give her a good mark. Really, I like the approach today. Apart from the
Yes.
driving and hypoglycemia, it's very important. The examination, I felt like you want and you know what to examine. You did and you offer everything. But again, the problem will be the time. Okay, so just try to manage your time and it will be much perfect. Okay, any question, Dr. Rasha?
No. Okay.
Okay, can you write the scenario for Dr. Hani?
Okay.
Any comment, Dr. Hani?
No, thank you.
Okay. By the way, if the case will be fundoscopy examination, just to reassure the candidate, it will be only fundoscopic examination. They will not give you examine the retinopathy or the retina and the nephropathy, the renal transplant, the peripheral neuropathy. No, it might be. This is what I noticed in the PACES experience. The fundoscopy will be offered in two stations or two scenarios: retinitis pigmentosa to find out the bony spiculi and the brown bony spiculi, and in complicated diabetes, which is related to the retinopathy itself. That's it. So you will not find other findings in the examination apart from the retinopathy. So the examiner will tell you, please go ahead. To say there is exudate, hard or soft, to say there is laser photocoagulation. This is the only scenario I heard about across the all experience in PACES. I didn't hear about other hypertensive, for example, retinopathy. I didn't hear about because it's very difficult to pick up it, and plus the patient will not have the dilatation. Okay. Yeah, Dr. Hani, your scenario will be shared. Give me a second. Yes, this is the scenario in the chat box. We will give you 2 or 3 minutes. We will have other discussion. Anyone want to comment? Dr. Hani, you are the doctor, senior house officer in the medical admission unit, 55 years old man referred by his GP for non-resolving cellulitis and leg ulcer. The man has been seeing the district nurse for regular dressing, but the ulceration is not improving. Culture of swab from this ulcer was negative a week ago, and the ulceration hasn't improved with fluoxetine. Flucloxacillin, okay? This is long, Dr. Asha, right? Just to confirm.
Yes.
Okay. Get ready, Dr. Hani. We will open the discussion. Anyone want to add any comment regarding the first case? To ask any question?
Oh, yes, I have comment, Dr. Basim. Sorry, I forget.
Yes.
About
Yes.
the case, the previous case. Yes, what is the problem if we put initial diagnosis adrenal insufficiency? Patient with diabetes came with vomiting and lose weight. So I think it is better in the
Look
judgment.
look at the blood pressure.
Yes, no, okay, blood pressure, but what I mean that we can put in the investigation AM cortisol or short synchrony test
Okay, it
because
might be
also
the fourth differential. Yeah, it's common to present and to come in paces,
yes.
but our case today, I don't think it could be fitting.
What I mean, Dr. Basim, the recent scenarios are where differential diagnosis, not a diagnosis.
Yes, yes.
Uh,
Okay, I agree. But give me a hint in the history to say this is possibly Addison and to put it strongly as a differential.
yes,
Give me
this is
two.
dizziness when standing from sitting position,
Okay,
or dizziness with low blood sugar with heartburn.
perfect. This is a very important point. So, low
Yes.
blood sugar nowadays, and the patient is telling to you, I am having low blood sugar and I decreased my insulin requirement or my insulin requirements are reduced. What the other, the third one?
Pigmentation. Pigmentation, but patient is old age. So
It's okay, you might have pigmentation and examination, but something in the history.
in the history about adrenal insufficiency,
Mm-hmm.
maybe dizziness.
This is the you mentioned already.
Okay.
The low blood sugar and the low requirement of insulin. And
Yes.
the last is important. It's
If the
related to the
patient on
diseases.
steroid, if the patient on steroid, patient immunosuppression medication.
Perfect.
No.
So this is as past history and he stopped it for any reason.
Yes.
Okay.
Yes. And also,
What?
Dr. Bassem, yes, about drugs of immunosuppressive, tacrolimus can cause lymphoma. So
And can cause high diabetes,
Mm.
raised blood sugar.
and can cause raised blood sugar. Yes.
Mm.
So it is complicated case.
Yes, I said
Dr.
it's
Hani.
very
Very complicated.
fatty case. It's difficult to be, but it can be. Be
Yes.
ready to have such case. And the good thing to train yourself on such complicated case. What I want to say regarding the Addison, the patient usually hypertensive. Nowadays, he's not taking the antihypertensive medication. So he will tell you, doctor, also I notice my blood pressure is low, or I feel dizzy and I'm not taking the blood pressure medication anymore. This is another hint. He is he is Addisonian likely. So you might have low blood sugar, low blood pressure, and what we mentioned already, the vomiting, abdominal pain, and hyperpigmentation, for example. Okay, all of them can be as a hint. Or you can also have another patient with TB, history of TB, so you can say TB adrenalitis, or as autoimmune, or post-meningococcal. So these are the extreme case of Addison, and you have to think about Addison and what the underlying cause of his Addison. It will not be as as I said. So let's repeat the sentence. Addison means autoimmune, right?
Yes. Associated with
Other
diabetes.
causes, exactly. So you will have it with diabetes or kidney disease or other autoimmune manifestation. What I want to say for the other cause of adrenal insufficiency, including the TB, post TB, or including post surgery,
Encephalitis.
or post encephalitis, or post meningococcal,
Meningococcal encephalitis.
meningococcal, yes, meningitis, or Nelson syndrome. You know the Nelson syndrome.
Yes.
Post what?
Post adrenectomy.
Perfect. Adrenalectomy. So these are the possible cause of adrenal insufficiency. And but as autoimmune, you have to say Addison disease. Okay. Also, the medications, stopping the steroid abruptly, it can cause adrenal insufficiency, but not Addison. So the term of Addison belong to the autoimmune
Yes.
adrenalitis. Okay. Good to raise this point, Dr. Mahmoud. Thank you.
So Dr. Bassem, Addison is autoimmune, primary
Yes.
autoimmune, and
Yes.
adrenal insufficiency may be primary or secondary. Yes, do you mean that?
Yes. Yeah. Other
Okay.
causes apart from the autoimmune.
Yes.
Okay.
Yes, Dr. Bassem.
But Addison also you can say it's adrenal insufficiency.
Yes, but
But
you
not
can.
every Exactly. Not
Adrenal
every.
insufficiency called Addison. Yes.
Yeah, but
Mm.
Addison is adrenal insufficiency. Perfect.
Autoimmune adrenal insufficiency.
Exactly. Yes.
Yes,
English.
doctor. Thank you, Dr. Bess. Thank you.
Most thank you. I think you're ready, Dr. Hani.
Okay.
Yes. Hey,
The name of the patient?
Dr.
The
Rasha, you
name
ready? You can ask the patient while discussing. It's okay if not mentioned. You can start by asking the patient name. Let's
Okay.
start. Yes. Here you go.
Hello there.
Hello.
I am Dr. Abdul Hafiz, one of the doctors in the clinic today. Can I confirm your age and name, please?
Yes, Ahmed, 55 years old.
Okay, nice to meet you, Mr. Ahmed. Mr. Ahmed, I am here to discuss your condition today, health condition. So I will ask you some questions, and after that I will examine you and address your concerns. Is it okay with you?
Yes, doctor.
Okay, can you tell me what brought you in hospital today?
Yes, doctor. I have skin soreness since into the 6th week. Despite the GB gave me antibiotic, which they called fluoxetillin, but still is not improved.
I am sorry to hear that, and I will try to do my best to help you. So can you just inform me the exact duration of this 6 weeks only?
Just only 6 weeks, yes, doctor.
Okay. So it will increase or decrease or the same?
Is it increase, doctor? And is it the painful?
Okay, painful. Where is the site exactly?
In my feet, my legs.
Okay. Where exactly in the leg?
In feet, doctor.
In the feet. Which foot? The right foot or the left foot?
In the right.
And which side of the foot? In the right foot.
In the right, yes.
And which side? In the outer side or the inner side or?
At the ankle joint.
At the ankle joint. Okay. In the inner side or the outer?
Is the inner side.
Okay. Okay. So it is painful. Am I right?
Yes. Yes, doctor.
Okay. So any discharge?
Yes, doctor. There's some of oozing, some of watery material.
Any bleeding from
No.
this?
No. No.
Okay. Any history of any redness around this ulcer?
No.
Okay. Any history of trauma?
No.
Okay. Any pain in the same leg during walking?
No.
Okay. So any numbness or change sensation in the feet?
No.
Okay. Any skin changes in other part of your body? Any skin rash, skin changes?
No.
Okay. Any joint pain?
Yes, doctor. I have joint pain.
Which joints?
In my knees.
Both knees.
No. Just only left knees. Left
knee.
Just only one.
Okay. And there is any swelling?
No, doctor. Since long time I have the pain in my knee.
Any specific diagnosis for this pain?
No, doctor.
Okay. Any other sites of any joint affected joint? Other affected joint?
Yes, sometime I have back pain.
Back pain. Okay. Any stiffness? Any stiffness in the morning?
No.
Okay. It is increased with movement or this back pain increased with movement?
No. Increased movement, no.
Okay. Relieved by rest?
Sometime, doctor, yes.
Okay. Any soreness in other parts of the body, like in your mouth, or I'm sorry for saying that it is in the private areas?
No.
Okay. Okay. So any high body temperature?
Sometime, doctor, yes. Recently, I have high body temperature.
Okay, since when?
The same period, 6 weeks.
It is mild or high? Very high.
It's mild, doctor. It's improved when I took paracetamol.
Okay, any lumps or bumps in your body?
No,
Okay, any change in your weight?
yes, my weight is lost, doctor.
How many kilos for how long?
Up to, doctor, is lost 1 kg over 3 months.
Okay, 1 kilogram only. Okay,
Mhm.
so any change in your appetite?
No,
Okay, any weakness in your limbs?
no,
Any problem in sensation, pins, needles, numbness in your hands or feet?
ask me, doctor, before. No,
Okay. Any headache?
no,
Okay. Any chest pain?
no,
Any shortness of breath?
no.
Any dizzy spells?
Yes, doctor.
Since when?
Since 1 week, doctor, I feel dizzy while standing from sitting position.
Okay. I'm sorry for that. So any leg swelling?
Any what?
Leg swelling.
No,
Okay. Any cough?
no,
Any coughing of blood?
no.
Any tummy pain?
Yes, doctor, I have tummy pain.
Where's the site of this pain?
In center my tummy, doctor.
Since when?
Since same period, doctor. Since 3 months back, doctor.
Any change in your bowel habits?
Bowel habit? Yes, doctor, I have loose motion.
Since when?
Since 3 months.
How many times per day?
Sometimes 3 and 4 times per day.
Any blood?
Yes, doctor, I have blood.
Okay. Any slime?
No,
Okay. So any your discoloration of your eyes or your skin?
no, I am not sure. No,
Okay. Any throwing up?
throwing up? No,
Okay. Any change in your water work?
no,
Okay. Any past history of any medical condition, long-standing condition? I will look.
no, no,
Any operations or procedures?
no.
Are you taking any medication or previously?
Just only, doctor, painkiller when I feel joint pain.
Okay. So any family history of the same condition or same problem?
Yes, doctor, my father has colon cancer, and also my mother has diabetes. Yes, and
Okay,
and
I'm
my
sorry to
sister,
hear
she
that.
has a gland problem.
Okay. Any diseases running in your family?
No,
Okay. So any recent travel history?
no,
Okay. Okay. So any problem in? Do you have a partner or married?
yes, doctor, I am married.
Any problem in your intimate relationship?
No,
What are you doing for a living?
I am businessman.
Okay, and how is this affecting your job and your daily life?
Yes, doctor, I can go to the work, doctor.
Okay. So do you smoke?
Yes,
Okay. How many cigarettes for how long?
3 or 5 cigarettes per day.
Okay. So you don't drink alcohol?
No.
Okay. Do you drive?
No what?
Do you drive?
No.
Okay. So can I examine you?
Yes.
Okay. I will start by general inspection. Any anorexia,
Any what?
any the patient built cachectic or normal?
No, normal body build.
Okay. So I will examine the foot. Can I see the?
Yes. I sent a picture, Dr. Basim.
Where is Richard? Dr. Basim?
Okay,
Can you
second,
share?
just second. I will share. Yes. She just sent to me.
Okay. I will examine the peripheral pulse, dorsal pedis.
In the chat box.
The first started with the dorsal. Okay. The palpable, peripheral pulse is palpable.
The peripheral pulse is palpable. Okay. I will. Okay, about this answer. Okay. So I will after that examine the abdomen examination. I will do firstly inspection, then palpation, superficial palpation, deep palpation, and percussion.
There's tenderness.
Where is the tenderness?
Into the left iliac fossa.
Left iliac fossa. Okay. Then after that, I will do the examination of the hands.
For what?
For any deformities, any swelling in the joints, any palmar edema, any pallor, any clubbing.
No deformity. There's pallor. There's no palmar erythema.
Any clubbing?
There's no clubbing.
Okay. I will check. I will examine the eyes for any pallor and any jaundice.
There's pallor, but there's no jaundice.
Okay. I will examine the mouth for any mouth ulcers, any central cyanosis.
There's no ulcer. There's no central cyanosis.
Okay. I will examine the back for any bibasal crepitations.
There's no basal crepitation.
I will check for any peripheral edema, rolling edema.
There's no peripheral edema.
Okay. Can I know what's your concern, Mr. Ahmed?
Doctor, I want to know what I have. Why this ulcer is not healing with the antibiotic?
I highly appreciate your concern, Mr. Ahmed. And from our discussion and examination of this soreness, okay, mostly it is a problem in your blood channels in the leg. Okay.
2 minutes left.
Okay. It is mostly there is stagnation in the blood in your leg, and there is soreness. Okay. So it is causing this ulceration, and this is one of the possibility. Second, maybe associated to this problem in your abdomen, in your tummy. Mostly it is a condition called inflammatory bowel disease, and it is maybe related to this condition. Okay, so we need to do some investigations to confirm our diagnosis, and after that we will give you the proper
Mhm.
management plan.
Doctor, why
عارفهم
is not improved with the antibiotic? Why is not healing with the antibiotic?
Yes, because it is not infection, not caused by infection or bacteria.
Mhm.
So it is
Okay.
not responding to the
Doctor, I
this
have a
antibiotic.
cancer because my father he had a cancer.
I highly appreciate your concern. So cancer, it is one of the possibilities. We need to exclude it by investigation. Okay.
I have skin cancer, you mean?
No, I mean this problem in your tummy. Not this problem in your skin. Okay. So we need to do some investigation to confirm our diagnosis and to exclude the other diagnosis.
Okay, time is up. Dr. Rasha, examiner question.
Okay, presenting your case.
Okay, I examined Mr. Ahmed. He's 55 years old, coming with 6 weeks ulceration in the foot, and in the right foot. Okay, there's discharge and it increases with time, and there's also joint pain and back pain, and there's history also of diarrhea and disease spells and low-grade fever and abdominal pain. So by examination, there is ulcer in the medial side of the right foot. Okay, it is irregular in margins and shallow, and there is red granulation tissue and surrounding inflammation. It seems to be chronic. Okay, and there is abdominal tenderness by examination of the abdomen in the left iliac fossa, and there is pallor. Okay.
What is most likely diagnosis?
Yes, the most likely diagnosis according to this the site of this ulcer, it will be venous leg ulcer. Location in the lower leg, and also in the margin, it is irregular and shallow.
What are the cause of the venous ulcer related this patient?
Sorry?
What are the cause of the venous ulcer related on this patient?
I suspect there is inflammatory bowel disease in this patient, according to the history from bloody diarrhea and joint pain and anemia, anemia, there is pallor. Also, maybe it is colon cancer. It is maybe associated to that.
Okay, how to investigate?
About investigation, I will do the basic blood investigations in the form of complete blood count and liver function test and renal function test and inflammatory markers and electrolytes. So after that, I want to swab done already. So I want to do ankle brachial pressure index and for suspicion of arterial, maybe arterial ulcer.
But peripheral bulk is palpable.
Yes. Yes.
Okay.
I will do also blood sugar and HbA1c. I will do Doppler ultrasound. Okay, and if also abdominal ultrasound and CT abdomen, okay, for searching
what?
for the underlying cause. For searching for the underlying cause, maybe gastric colonic cancer, and I will do fecal elastase and
What fecal elastase? For what fecal elastase?
not fecal elastase. Fecoprotectin.
Test for this patient.
Sorry.
What is the most accurate test regarding this patient?
For this ulcer?
Yes.
Biopsy.
Yes. How to investigate inflammatory bowel disease?
I will do colonoscopy. Okay. And upper endoscopy also.
Upper endoscopy for what?
If I suspect this is maybe ulcerative colitis, maybe Crohn's, we will need upper and lower endoscopy and with biopsy. Okay.
How
I
to
will do also yes,
Crohn's and ulcerative colitis?
Stochastic. So, and I will do X-ray in the knee, left knee, and lumbosacral spines.
What are the cause of the joint pain in this patient?
Inflammatory bowel disease can cause joint pain.
Okay, how can differentiate it between Crohn's and ulcerative colitis?
By histologically, it is ulcerative colitis will take the mucosa and underlying submucosal tissue. Crohn's will take all the layers. Ulcerative colitis can take all the bowel from the mouth to the anus. But Crohn's it is taking the colon, okay, affecting the colon. There is skip lesions in ulcerative colitis. There is in Crohn's there is abscesses, okay, or granulomas, okay.
How to treat?
According to the diagnosis, firstly, I will. It is one multidisciplinary team approach. I will involve gastroenterologist, okay, and also a general surgery specialist and vascular surgery specialist. Non-pharmacological by caring of this ulcer and daily dressing and in treatment stopping smoking, treatment of the underlying cause if there is inflammatory bowel disease or any cancer. Okay. This is my treatment.
Okay, that's enough. Any other question, Dr. Rasha?
No.
Okay. Any invasive procedure, Dr. Hani? The last question. You mentioned the invasive. What you will do?
You mentioned colonoscopy and upper GI.
Okay, that's it. Okay, thank you. Your comment, Dr. Rasha?
Yes, regarding this case, yes, first of all, this is the case by dermagranulosum, okay, due to the underlying inflammatory bowel disease. But you needed to exclude the other causes, other differential diagnosis of bioderma. You asked me about the ulcer on which side, the inner side or outside. I can understand the questions. What is the difference between inner side and the outer side? Because if the patient have ulcer, you ask the patient, may I have a look in the first? Hello?
Yes. with you.
Yes. First of all, يعني if the patient have ulcer, عشان not taken to the time, you need ask the patient, may I have a look? If they seen the patient the ulcer, because that maybe patient complain the ulcer, inside the patient يطلع vitiligo or patient by the erythema nodosum. For that, if the patient any skin lesion, at the first you need ask the patient, may I have a look? Okay. The first of all. The second, you ask me about the pain into the walking and ask me about pins and needle sensation. I think this is the questions is not regarding this case, okay? And ask me about ask me about the bleeding. When I said I bleeding with the blood, is didn't ask me is mixed with the stool or fresh blood, to know exactly if the patient ulcerative colitis or rectal bleeding. Okay, and also ask me about the intimate relationship. I think in this patient is not irrelevant questions about the patient intimate relationship. Yes, regarding to the examination, regarding to the history, when I said
Dr. Rasha, wait please. For the question of intimacy or having another partner or casual relationships, it can make sense if the case is reactive arthritis. This is what I expect. This lesion is the lesion of reactive arthritis in the sole before looking to the picture. So maybe it
Yes.
can make sense.
But if reactive arthritis, there's other symptom like
Yeah, exactly.
scars
Yes.
and something like that.
Perfect. Okay, continue.
Okay. Yes. Okay. Regarding to the history, okay. It didn't. Okay. It didn't ask me about the other differential diagnosis of pyoderma granulosum. It didn't ask me about the psoriasis, because psoriasis also can be caused by derma granulosum. And also, if the patient presented with any skin manifestation, you need to ask about the other related to the skin manifestation. You need to ask about the nail and the eye and the skin and the mouth. Any skin lesion, you need to ask about this. Okay, it didn't ask about the systemic lupus, because the systemic lupus, one of the differential diagnoses of pyoderma granulosum. Regarding to the examination, look and feel and move. Okay, you started with the pulse, examine to the pulse without looking and describing to the lesion. Okay, and after that, examine to the abdomen.
No, just I waited for sharing just
Yes,
the picture.
okay, no problem. Okay, when examined to the abdomen, the patient presented with pain or tenderness into the left iliac fossa, maybe patient ulcerative colitis, okay? You didn't offer the patient to do BR examination. Offer to the patient to BR examination. In examination to the patient presented with the pallor, you need to examine to the lymph node to rule out the malignancy. Even the patient didn't have any history of lymphadenopathy, you need to examine to the lymph node to rule out the malignancy, okay? This is my comment. Okay. Regarding to the investigation, you need admitting to the patient and do X-ray to the abdomen to rule out toxic megacolon, because the patient presented with the blood and anemia and the patient diarrhea. Okay, is the important. And also you need to tell the patient you need to the urgent endoscopy, because the patient irritable inflammatory bowel disease needing to the patient urgent OGD and urgent abdominal X-ray to rule out toxic megacolon. Regarding to the investigation, patient inflammatory bowel disease, you needed to sigmoidoscopy and biopsy. And full blood count for anemia and inflammatory marker to rule out the acute stage of inflammatory bowel disease. Okay, it didn't ask me about any family history of the skin cancer. Is important because the patient presented with a skin lesion.
Actually, when I see the picture, I became confused, because I think it is not the usual site of pyoderma granulosum in this site.
But
this
can be presented
this
to
confused me more.
any side. Yes.
You're
The
right,
common
Dr. Hani, but it's
yes.
characteristic. It's put diagnosis. You
And
can look at
present
it again.
to any side. Yes.
Yeah, it's the same picture of pyoderma gangrenosum. Ulcer with, I think, gangrenous boundaries. So it's the spot diagnosis of pyoderma gangrenosum. Anyway, you can suspect cancer still, because you don't know what
the
you have
cancer.
to do
Yes,
the
the cancer
biopsy.
of one possibility.
Exactly.
Related to family history and the patient عندها weight loss. the one of the possibility. And also inflammatory bowel disease leading to the cancer, yeah. Colon cancer, risk for the colon cancer.
Exactly. The other thing, sorry, Dr. Rasha, it's not painful. However, it looks ugly, but no pain. In contrast to the erythema, the erythema nodosum, it's very painful. There is some cases it will be painful, but usually it's not painful. Bioderma gangrenosum, in comparison with erythema nodosum, the bioderma gangrenosum is painless. However, the erythema nodosum are painful. Okay, continue, Dr. Ashraf.
Yes, but I think sometime may be painful. I'm not sure. Okay.
Yeah, there is possibility. It's not a classic, but the usual one by default, it's not painful. Remember, the shape is ugly and it sounds that it's painful. However, it's not usually painful. Continue.
Okay. You didn't ask me about what increase, what decrease, because maybe related to the smoking or alcohol or medication or sun exposure, ulcer maybe. What is increase the ulcer and what the decrease? Yes, finish.
Okay, so let's comment on the skills, physical examination.
Regarding to the physical examination, is the important to this patient to check the sign of chronic liver disease and the sign of malignancy like lymphoadenopathy is important because one of the differential diagnosis.
Okay, they identify the signs, so there is minus at least 2 marks here. Continue. They identify the signs. Any
Yes, the concern is okay, but judgment
No,
the
no.
patient.
Not the identify signs. The skill of identify the signs.
Yes, because identify this. A patient don't have any sign, but you needed to rule out other differential. You needed to looking the chronic liver disease, lymphoadenopathy.
Okay, this is for physical examination because no finding, he will not pick up anything, so it will be in the physical sign. But in the physical or identify the signs will be satisfactory, right? Because he examined the tummy, the abdomen, I mean, and he examined the lesion itself, right?
Yes.
Okay. Now we will go to the next clinical communication. How was the history?
Yes, the history missed some point. What increase, what decrease, and also the questions, the inner side or outside is not clear for me. And also you take the time to ask about, may I have a look? You need to the first question, ask the patient, may I have a look? And ask me about the pain while walking. I said no. Ask me about intimate relationship. I think this question is irrelevant. Taking the time.
Okay, continue. The differential diagnosis.
Differential diagnosis, inflammatory bowel disease. You said inflammatory bowel disease, but you tell the patient this have problem into the blood vessel, and also tell the examiner the patient maybe have venous ulcer. I think the venous ulcer at the site into the medial manulus.
Yes, okay.
Yes, I think, and there's other risk of the venous ulcer.
Yes, you're right, but let's assume in the exam and based on the skills of differential diagnosis, if you look at the paper or mark sheet, they wrote that if you mention the second, your diagnosis is the second differential, so they will give you the good mark or the full mark. So no harm. Yes, it's not the case as a chronic or venous ulcer, but he mentioned it as second differential. So I can give him satisfactory in the differential. Okay. Clinical judgment.
The clinical judgment, you need to tell the patient you need admitting to the patient and do OGD and abdominal X-ray. I think is important to rule out to diagnosis and rule out the complication.
Okay, and he mentioned all of these steps.
He mentioned upper yes. He mentioned the examiner OGD, but not tell the patient you need into the OGD.
No need the patient. Yeah, at least he mentioned to the examiner.
Yes, need to urgent OGD.
Okay. Then the concerns.
The concern,
He
tell me the concern, yes, is because yes, when I tell him why doctor is not improved with the antibiotic, yes, is it inflammation, is not related to the underlying condition, is not infectious by the bacterial infection.
Okay.
Is it cancer? Yes, is maybe it can cancer. For that you needed to other further investigation to exclude.
Okay, so let's ask Dr. Hani advanced question. What the treatment of pyoderma gangrenosum?
I think it is corticosteroids. Okay.
What type of steroid? Don't give me name. I said what type. I didn't say what the name. Type.
What you mean type?
Okay, is it? I will give you options. Is it potent steroid, topical steroid, or is it mild dose
No,
topical
it is
steroid?
oral steroids. Oral.
No, it's topical. It's not oral.
Hmm.
A potent topical steroid. And what else you can give? Topical.
Immunosuppressive.
Like, give me name. Topical also.
Hmm.
Yes. Yes. Is it? It is the one. It is the one.
Tacrolimus.
Tacrolimus. Yeah, tacrolimus. Yes, tacrolimus.
Hmm.
Yeah, perfect. Okay. Any any other comment or question, Dr. Rasha, you want to add?
Yes, needed to check your blood pressure sitting or standing, because I tell him I have dizziness when they're sitting or standing, and the patient also anemia. You need to check your blood pressure sitting or standing. Offer يعني offer.
Okay.
Mhm.
So you can look at the judgment, anything you want to minus. I minus him in the physical examination and in the clinical communication. Anything else you want to mark his down in?
No.
Okay. Dr. Hani, any question or comment?
About the treatment of bioderma gangrenosum.
Yes.
I think it is different if it is associated to inflammatory bowel disease or what?
Yes, you have to mention.
Mm.
You have to mention if it's related to underlying inflammatory bowel disease, I have to treat the cause. So you have to say it. I will treat the cause, which is inflammatory bowel disease or ulcerative colitis in particular. But there is topical management or topical medication can be applied, which is I mentioned steroid, topical potent steroid or topical tacrolimus. Okay.
Mm. Okay.
Any other question?
About the picture, actually, I think in this site it will be confused if it is come in the exam in this.
It's okay to put it as a differential, Dr. Hani. Put it as a differential, as a chronic venous insufficiency ulcer or chronic venous ulcer. But the history and the hint, yes, the hint is clear. There is inflammatory bowel disease, diarrhea with blood, abdominal pain. So I should think, and the surrogate is helping you and trying to push you to this diagnosis, bioderma gangrenosum. And the picture itself is spot diagnosis, as I said. It's not only in the leg side, any area, sometimes above the chin. It's not only the medial chin. Okay. But usually in the lower limb or in the leg.
Okay.
Yes, because مش dermatologist وكل الدرماتولوجيست you need to do the biopsy، لكن السكند الاسوسيشن symptom هي go to the diagnosis. يعني a lot of يعني البيكتشر مش same not like the patient itself، يعني مرات تكون البيكتشر مختلفة، لكن go to the diagnosis ال other differential diagnosis ال other symptom with the patient. يعني البيشنت هذه كانت bloody with the diarrhea with the blood with the stool، ال other back pain, arthritis، all of these go to the patient inflammatory bowel disease. Not exactly the skin rash go to the inflammatory bowel disease.
Perfect. Also, there is manifestation in the eyes. Did you ask about the vision? Redness.
Redness, yes.
It's important because also you might address the driving in this scenario. One of the extra-intestinal manifestation in the ulcer
Also, yes,
colitis.
exercise manifestation as a part of disease, yes.
Yes. So you have to ask about it. And the clue here was the joint. You did the good systemic review, by the way. That's why you catch the relevant system or the system affected, which is the musculoskeletal. And I think it guides you to ask about other systemic question. And you found also the diarrhea, loose motion. It's a tricky case, but whenever, this is the golden advice, as Dr. Rasha said, any patient with rash, skin lesion, something the patient can show you, immediately ask him, please show me. Even you will move to the patient and will be back to the examiner or your chair, it's okay. At least I will be narrowed to differential diagnosis, which can make sense. Better than asking everywhere and a nonsensible question to the examiner. And the time, of course, will be also utilized for that unnecessary question. So I will be targeted to, for example, in this scenario, I will be targeted to the ulcerative
I think
colitis.
I think in this case, if I see you firstly, I would be confused more. But in this case,
No. I think
is
I went, I saw it. I know this is Bioderma gangrenosum. You will not forget it again. Look at
okay.
different picture in the
So, uh,
Google. Yes.
what is the difference if we about is just the picture? What is the difference in the picture between the venous ulcer and Bioderma gangrenosum?
The
What's the
venous
difference?
ulcer will be in the medial malleolus, as Dr. Rasha said. You will have
Yes.
swelling, the edema around or even upward to the ankle or above to the knee. Okay,
Mm.
you will have tortuous and engorged veins. Right, there is venous engagement or there is congestion in the leg, and that's why the
Mm.
patient is having this ulcer. But here you don't have anything, just the ulcer. Be
Mm.
sure that the chronic or the venous ulcer will be associated with the things I mentioned. Plus, the patient will have, for example, occupational standing long time. He has history of varices, other varices like testicular torsion or the varices in the testis, what we call it, testicular varices. Uh, uh, what we call the varices, varicocele, yes. So you will have other possibility to have dilated or congested vein. Plus, diabetes also can be there as a complication of diabetes. But it's not restricted to the diabetes or to the chronic venous ulcer as a diagnosis. Whenever you have other clues, as in this scenario, move your differential to the inflammatory bowel disease or ulcerative colitis and Bioderma gangrenosum. Okay.
Okay.
But the good thing you mention it as second differential. According to the skill and the mark sheet, if included in the second differential, you can gain the full mark.
Okay. Thank you,
Okay.
Dr. Basim. جزاك الله خير.
Thank you, Dr. Hani.
Thank you, Dr. Rashid.
لا العفو.
What was the third differential, Dr. Rasha, for this case? Cancer? Still a cancer, the cancer one or the differential?
Yeah, the third, because this is a case from the rider. The first differential diagnosis inflammatory, second cancer.
Okay. So, Dr. Hani, add to rider another differential. You can
We can
add it.
put we can put the arterial ulcer, venous ulcer, and the neuropathic ulcer.
I don't think you can put arterial here as long as you felt the beatal pulse. Difficult to say this is arterial pulse. And the arterial one will be at the tip of the finger or the heel of the heel of the ankle. The least supplied area or vasculature in the foot. The big two and the heel. This is the most common area of arterial ulcer. The neuropathic one, you will have it at I think bony prominence, right? Prominence, the bony prominence, like the base of the right two or the base of the two, because of trauma. So the patient will hit this area, and he will not feel it, and it will be complicated with the ulcer. These are the difference between all three ulcers, right? And again, the medial one, the venous one, will be medial malleolus. And it will be associated with congestion or stasis or standing or varices with engorged vein again. Okay, any other question? Pressure area, yes, doctor. Yeah, the pressure area. So the pressure area will be for the vascular or the arterial one.
Okay.
Thank you, Dr. Hani. Dr. Rasha, any question?
جزاك الله خير.
جزاك الله خير. شكرا دكتور.
Okay, thank you. Thank you too. Let's read the comment quickly. Yeah, crypt abscess. You mentioned Crohn's abscess. It's crypt abscess,
Yes.
right? Crypt abscess. This is the histopathological finding of the ulcerative colitis. Fecal calprotectin. This is the diagnostic investigation or workup. And I want just to correct it. Crypt abscess. Okay, we mention it. The golden advice, we mention it. Pain with walking because you need to exclude arterial. Yes, this is also another clue to have arterial ulcer. The patient will have claudication, and usually it's
I
happening.
asked it.
Yeah,
I
yes, I
asked
mean you
about
ask. I'm reading the comment to confirm the information. So it will be confirmed by history of claudication while walking. You will have arterial insufficiency as a confirmatory test, and the arterial ankle brachial index will be diagnostic for the arterial one, right? Vascular cause, numbness may be neuropathic. Yes, you will have also associated peripheral neuropathy. Perfect. This is another clue. And then the next, this photo, I hope, Dr. Hani, you already shared it there in the chat, in the WhatsApp group. I think this is the venous. Yes, this is the venous, right? The photo you mentioned. This is the medial malleolus. It's characteristic for venous ulcer. To request vital sign, I think it's important and examine hands for clapping. Asking for eye symptom, perfect. Redness in the past, jaundice, perfect. This is also to address the driving, it's very important. Pain when associated with the inflammatory, yes, it's painless. Yes, as I said. Tacrolimus, exactly. This picture, I think, for bioderma gangrenosum, the one and the second one, Tacrolimus as a topical management. And bioderma gangrenosum, when it starts as lump, blister, then Dr. Nada, less pain, but when become deep ulcer, it's painful. Yes. Pressure areas, neuropathic ulcer. Perfect. Okay. Anyone want to add any question or to add any comment?
السلام عليكم دكتور هاني.
عليكم السلام.
دكتور باسم.
Yes,
Yes, I feel comment.
Sure, doctor.
I guess you did well in this case. A few comments that not to be missed in the exam. When we start our examination, we should ask about the vital signs, especially here, as Dr. Rasha mentioned, blood pressure, sitting and standing, and body mass index of situation is mandatory. Okay, vital sign, it's very important. We should start by vital signs and inspection. Then after that, enhanced examination, because even the patient has no clinical finding rather than this ulcer, to search about other findings associated with ulcerative or inflammatory bowel disease in general, it is important to say to the examiner, I couldn't appreciate any finding here and here. Eye examination and searching about sacroiliitis, especially the patient complain of back pain. And also, what else which is important in examination, I need to be mentioned here, mouth soreness, he already did, but redness in the eye now or in the past, and offer to do eye examination. So seeking for any something in the eye. Abdominal examination mandatory. Bioderma gangrenosum, already he did this. Also, my comment in that clinical judgment regarding to admit urgent this patient, I guess he's in a cold case. He's in antibiotic for several weeks. Now, if he has symptoms like GI symptoms like diarrhea, vomiting, dehydrated, or anything else, we can mention that you can keep with you for a while to do some investigation, but we need to do camera test regarding this and this. But earlier admission, I guess it is not that very much important. What do you think, guys? And
Yeah.
yes, I will comment about
before.
this, and you can comment.
Okay, continue.
Yes, when you ask him discussion examiner questions, what is the first line for managing pyoderma gangrenosum? The first line is oral prednisolone, according to the NICE guidelines. And the second line is typical tacrolimus. And this is oral prednisolone also can help in ulcerative colitis or this inflammatory bowel disease as well. Thank you.
Perfect. Thank you, Doctor. What's your name? Your good name, please.
Mihera.
Okay, Dr. Mia, thank you for your comment. Really, it's a helpful comment, informative one. I will just add to the admission decision. Any patient with symptomatic anemia, he should be admitted for the workup, plus for the possibility of blood transfusion. Right? Agree with this?
Yes, yeah. You mentioned
I think,
I'm busy in the history.
Yeah, there is dizziness.
Yes.
And there is a bloody stool. So this is, I think it's important decision. It can make a difference with the patient. Plus, it makes sense with the examiner.
Yes.
Yeah, other comment, yes, you're right. It's a valid comment. Thank you for your comment. And also, please, at any time you have information you want to share, sometimes I'm not covering the whole topic, sometimes missed small points. Anyone had the information to confirm, to add, it's your session, not only mine, okay? So I would like to say hello to everyone. Thank you also for sharing your information. And at any time, you can share any information, not only you, anyone. So thank you again, Dr. Mohira. Thank you, Dr. Hani, Dr. Rasha, and other attendee today. Any question before ending the session?
Thank you. Jazakallah khair, Doctor.
It is very precious session, really. Thank you very much.
Okay, thank you, Doctor. And you are welcome at any session and on any day, and anyone, of course, to attend our session. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.